everyone. My name is Vanessa Blumer. I'm an advanced heart failure and transplant cardiologist at Innova Heart and Vascular. I hold dual roles as an associate director for heart failure research and co-director for heart failure outreach. It was an honor to be able to chair this American Heart Association scientific statement that we will be discussing today. And it was a total pleasure to work alongside an incredible team of co-authors, including Dr. Manreet Kanwar, who will be joining me today and served as the vice chair for this scientific statement.
Hi, everyone. My name is Manreet Kanwar. Like Vanessa, I'm also a heart failure cardiologist, although I practice in Pittsburgh, Pennsylvania. At my institution, I hold the role of being the director of the LVAD Transplant and Shock Program, and I'm also the co-section lead for pulmonary hypertension and advanced heart failure at Allegheny Health Network.
We are very thrilled to be discussing our AHA scientific statement on cardiogenic shock in older adults. And this is going to be a focus on age-associated risks and approach to management.
Before we begin our discussion, I would like to thank American Heart Association on behalf of the co-authors, myself and Vanessa, for commissioning the scientific statement, as well as their immense support throughout the entire process.
Thank you to the AHA. And Manreet, why don't we begin by discussing why we focused on cardiogenic shock in older adults for this scientific statement?
Sure. So Vanessa, as you know, cardiogenic shock, despite all the recent influx of information, randomized control trials, and other research that's being done on the topic, unfortunately continues to have a very high mortality, nearly 30 to 50%, depending on where you're looking. Patients who present with cardiogenic shock end up dying during the index hospitalization. Now, of course, survival itself is dependent on many, many different factors. Why they are in shock, how sick they are when they first come in, what is done to treat them. But one thing, specifically in this case, age plays a crucial role in predicting or sort of having a risk assessment profile on how they will do. And as we all know, age is a non-modifiable risk factor. And regardless of how they present compared to their younger counterparts, older patients continue to have higher death rates in the hospital, regardless of why they are in shock and how sick they are when they first come in. So those were some of my reasons why I wanted to work on this topic. How about you? Do you think this was in alignment in what you had in mind when we picked the topic?
Yeah, no, precisely. I think you summarized that very nicely. I think on top of that, it's not just that cardiogenic shock is more common in older adults and that obviously it's highly prevalent, but perhaps more importantly, I think that like you pointed out, age significantly influences treatment decisions in this patient population, particularly regarding invasive procedures and escalation of care. For instance, while heart transplant centers often have age limits for patients, the criteria for older adults to receive durable left ventricular assist devices varies widely between centers, and some still reference age as a limitation for patients to receive LVAD.
And sure, at some level, I understand why that is. And yet, when we look at other clinical presentations, so let's say patients who have a heart attack, may not necessarily be in shock, patients who have severe valve disease, even if those illnesses are presenting at the same age profile, the very elderly, let's say octogenarians, nonagenarians, their outcomes have actually started to improve and mirror those of their younger counterparts. But we haven't necessarily seen that mirrored in cardiogenic shock patients. Now, part of the problem, of course, is that these patients, these extreme age groups, are often not included in our clinical trials, so they're not represented in the data that we seek to see how we can improve their outcomes. So this unfortunately leaves us with a significant knowledge gap in this area, so we don't really truly understand, is it age alone or is it something else that's driving their higher rates of mortality during hospitalization?
I think that's another key point in terms of gap in knowledge gap and gap in guidelines, which we know across cardiogenic shock. And I think this is why our statement, throughout the entire statement, we emphasize the need for a more comprehensive and interdisciplinary approach when we're assessing and treating older adults.
Yep, absolutely. And in fact, in this particular AHA statement, that's why we started with summarizing what we already know, especially in this particular vulnerable age population, and then focus in on risk assessment that would be specific to this age group, and then hospital management, how these patients tend to do. So we start with what we know, but then go on to also address the knowledge gaps, as we talked about earlier. And the hope is that within this summary statement, we are providing expert opinions. Now, unfortunately, as mentioned earlier, these patients are not often included in trials, so we don't really have a lot of guidelines necessarily. So instead, we did the next best thing, which was expert opinion and clinical practice suggestions on how to approach this otherwise vulnerable patient population who presents in cardiogenic shock.
Yeah, that's correct. So I think this kind of served as a little bit of a background. Now let's delve into key takeaways from our statement. I think one of the first challenges that we had or that we identified early on was the inconsistent definitions, particularly for older adults. This inconsistency when defining older adults, specifically for individuals of 75 and above, created a significant knowledge gap in evidence-based recommendations. Manreet, what are your thoughts on this?
So I agree, Vanessa. One of the issues, of course, is age is an absolute number for sure. But then there's chronological age and then there's a physiological age. And I'm sure we can look at it in different sort of viewpoints. Currently, our decision making rests on age as an absolute number. So to say that a 75-year-old would qualify for, let's say, treatment modality, but a 76-year-old would not, of course, creates these arbitrary cutoffs when defining who is in this elderly age group patient population. But then there's the age itself and then what comes with that age. Unfortunately, these patients often have a higher comorbidity disease burden. They're more likely to be diabetic, have high blood pressure, maybe they've had a stroke. So all these multiple morbidities come in as a part of package deal of the chronological age. And these patients also tend to have higher frailty scores. They're more likely to be sicker with the same presentation, maybe even having delirium, for example. They're often subject to polypharmacy issues just by virtue of being in that age group. So there's age in itself as a number, and then the other associations that come in with being in that age group that I think have to be all taken in totality when looking at this patient population.
Yeah, absolutely. I think we've all treated a patient before where we say the patient is 78, but the patient is a very young 78, or the opposite. So while age is recognized as a factor that can increase mortality risk in older adults, it shouldn't be the sole determinant of risk. Our approach needs to be individualized, and it should consider a range of contributing factors. And this is perhaps one of the most important key takeaways from this scientific statement.
That actually brings us to another important point. As important as you were alluding to earlier, it is to make an individualized patient decision, taking into account, of course, their age, but also other things that come with age, their comorbidities, etc. I think the key thing is having a truly interdisciplinary approach to cardiogenic shock, especially in this vulnerable patient population. So we've learned over the years from work that done at your institution and others that cardiogenic shock team approach, interdisciplinary, involving our cardiothoracic surgeons, our interventional cardiologists, heart failure docs, etc., but also including our supportive and palliative care teams, for example, is key in making sure that the decisions we make for this patient population are in alignment with what they would want as their goals for shock care are. And I think getting this idea is to individualize decision making, but in an interdisciplinary fashion. I think if we can find the right balance between the two, this can allow us to hopefully continue to improve outcomes in this age group.
Yeah, that's amazing, Manreet. And for the readers, this is all very nicely summarized in Figure 1, where we try to highlight the important aspects that should be considered in decision-making in cardiogenic shock. Like Manreet so nicely pointed out, risk assessment in cardiogenic shock, especially among older adults, requires an interdisciplinary approach, and the decision-making process involves considering individual patient factors, relevant aspects of the clinical trajectory, and also the capabilities of the healthcare center.
One way of looking at it, it's really about aligning what treatment options we are considering for that patient with their goal, be it quality or longevity of life, making sure that what we're offering them is what they want for themselves. Often, unfortunately, in this patient population, they may not be able to make these decisions right away. So finding out who is their health proxy or what would be their care preference hopefully directly from the patient, but in the absence of that choice, identifying who is the, maybe a surrogate decision maker for this particular patient who can help us understand, making sure that we're not, not sticking to the patient's wishes, and more importantly, adhering to the principles of beneficence and non-maleficence.
Absolutely, Manreet. That's also a critical point. So we don't want to give away the entire scientific statement because we obviously want you all to read it, but perhaps the other key takeaway has to do with management of cardiogenic shock in older adults. Manreet, what do you think are the key takeaways points here?
I think, again, in continuation with what we were talking about, to me, the key take home points were trying to make patient centric decisions and then also making sure we are making these decisions using the benefits of an interdisciplinary heart team approach, especially when it comes to invasive therapies, because even if the patient may be a suitable candidate for temporary mechanical circulatory support, for example, we need to figure out what is their exit strategy. Are these patients who will also go on to, let's say, receive an LVAD or a transplant if eligible for, or will they be candidates for bypass or revascularization, whatever it is that they may need? So I think before we offer these patients invasive therapies or assume that this is what they want, having had that discussion to the best of our ability, either with the patient themselves and or their caregivers in an interdisciplinary fashion, if we can manage that, I think that would be ideal.
That's awesome. And we try to summarize our approach to management in figure 2, where we try to highlight that irrespective of age, the initial treatment approach for patients with cardiogenic shock should prioritize early recognition, initial stabilization, and timely identification of those patients that require transfer to higher level care. And like Manreet said, an interdisciplinary risk assessment and implementation of appropriate care pathways should be tailored to individual phenotypes. And age is just one factor to be considered. For all cardiogenic shock patients, regardless of age, management goals encompass decongestion, restoration of perfusion, limitation of multi-organ dysfunction, and evaluation of risk and benefits of treatment escalation. And then for each patient, the trajectory is unique and should take into account, and we can't stress this enough, patient factors, clinical trajectory, and then the center capabilities, all while considering potential exit strategies, which includes recovery, durable left ventricular assist devices, heart transplantation, or transitioning to comfort care.
Absolutely. And one thing I know mentioned this earlier, but I would still like to emphasize, as you said, age shouldn't be the only number that predicts somebody's treatment strategy. And yet, having said that, especially if you're talking extremes of age, it is an important number. So before we subject anybody to mechanical circulatory support, invasive therapies, be it intra-aortic balloon pump, Impella, ECMO, whatever that may be, to have a sense of how we're going to get this machine therapy off of this patient, or at least even if we don't know if the patient is eligible for VAD or transplant, or their desires are not abundantly clear, we shouldn't also always assume that this person would want this. So same thing as saying age shouldn't be the only reason to consider before proceeding with these therapies, but having some semblance of what is your exit strategy. Because if there is clearly none, sometimes it's important to stop and think thrice before subjecting these patients to these invasive options without really having a sense of what we're going to do. So before escalation, during ongoing management on temporary MCS, and then also while de-escalation, during the escalation process, especially let's say you're liberating them of a temporary mechanical circulatory support, having had the discussion of if the patient doesn't do well, are we gonna re-implant this therapy, for example? So again, the idea is understanding the patient's goals for themselves, and knowing that sometimes it's easier said than done in these very, very critically sick patients, but at least making every effort to understand what their patient's wishes are, what your center's capabilities are, what would be a viable exit strategy, and taking all of these factors into consideration, not just at the time of admission, but on an ongoing basis with the support of your palliative care and or supportive care teams, I think would be an ideal approach.
Absolutely, Manreet. I think that point is extremely important. And you mentioned temporary MCS. I also want to make a point of durable LVADs for older adults. I think in the same way, we can't just focus on age when we're talking about durable LVADs. We also should focus on other comorbidities of advanced heart failure, including frailty and end organ dysfunction, before we say that someone will not derive benefit from an LVAD. So in this sense, shared decision making is also key, reviewing benefits, risks, and burdens, as well as other options like palliative care when we deem that these patients will not derive any benefit from these therapies.
For sure, for sure. And I think to wrap up, I would like to think about how we approach this document, and the message we're trying to get across is risk assessment is key in cardiogenic shock, especially in this elderly patient population, should be done using an interdisciplinary approach. The idea is that you customize your approach in treatment strategies to what the patient's unique needs are. You monitor them closely. You adapt your treatment strategy based on more information learned that you may not have had at the time of their initial presentation. And this would really allow you to effectively utilize your resources, ICU beds, temporary MCS therapies, et cetera, in the best effective manner possible.
This has been a fantastic discussion, Manreet. Thank you so much for doing this. We hope that we've piqued your interest without giving too much away, and that you're all now eager to delve into the full statement. Before concluding, we like to extend our heartfelt gratitude to the writing group for their invaluable contributions. It was truly an extraordinary group of people, and a huge thank you to the AHA for the opportunity. We strongly encourage everyone to read our paper for a comprehensive understanding of cardiogenic shock in older adults.
I couldn't have said it better. Thank you so much for joining us. We hope you find the paper informative and it can help guide your clinical practice. Thank you for your time.